Lots of friends I knew who were nurses and medical people said that we should have had palliative care involved with Mum much earlier because there were a lot of issues with getting medications right and things like that. But Mum always liked to do what her oncologist told her to do, and her oncologist said to her that she was nowhere near that stage. So there's this perception that palliative care can only help you when you're ready to die, and it's just not true.
Palliative care does frighten people because of its traditional association with the dying phase of illness, but it's really important to get the message out there that palliative care equally is for people with any degree of symptom that needs addressing, or any degree of psychosocial or psychological or emotional dimension that needs to be addressed by those of us that are caring for them. And the earlier the referral comes to palliative care, the better it usually is for patients and their families. And I have to say, it's my experience and that of all of us who work in palliative care that it's often an enormous relief for people to be referred to the palliative care service, whatever misgivings they might have, to discover that it doesn't mean that they're about to die next week, and that we can do a whole lot to make things a lot better for them, hopefully for many months before the illness starts to take more of a toll and we start thinking about time being limited.
We didn't want to leave palliative care as something that you do under stress, or I didn't. I wasn't prepared to do that. So probably a year ago, when he was very, very well, I got numbers from the public hospital that he was seen at. Numbers, phone numbers, a couple of names, because I don't think it's something that you need to do when you're stressed. But by the same token, we shouldn't have had to do that.
No, whereas Leanne did that, whereas it was never ever offered to me. So even today, I'd be still in the, if he took desperately ill and needed palliative care in the next 2 weeks, I really wouldn't know where to go. I'd have to go to probably start with the doctor and say, well, what do you do? And perhaps that's what they're waiting for.
You're so out of control with all this. You really just need some sense of control. And if you had that pack in the bottom drawer, you know, for when you need it, it's just getting a little bit of the control back in a situation that you've got none in.
Look, it's really important, I think, for people to be proactive again about this, just as patients have misgivings about what palliative care has to offer, and despite all the educational efforts that we make, many doctors, particularly doctors who've been working in the healthcare system, you know, for longer than, you know, say the last 15 or 20 years, will have the same perception that palliative care is only for the very final stages of life. So if patients are feeling, as they listen to what I've got to say, that yes, they've got a symptom, that they want to discuss what's going on with palliative care, they can and should be proactive. And if their doctor doesn't seem to be keen to make a referral for whatever reason, then the patients should feel free to make a self-referral to the palliative care service. Most services will require some involvement of people's own general practitioner, and we find that if we contact the general practitioner to say that we've had a request to see the patient, it would be vanishingly rare for a general practitioner to say, no thanks, I don't need that for my patient, and particularly when the patient has actually asked for this.
As a doctor, as a family doctor, we have the duty to inform our patient what help is needed, what the future will be, and our duty is to relieve suffering, and that is the best thing to do. By relieving suffering, we're including economic suffering, psychological suffering, and actually physical pain suffering. So that is why I'm sort of multi-discipline sort of approach is absolutely essential.
There are a number of symptoms which are important to understand and treat appropriately with specialist care that happen to people with a diagnosis of pancreatic cancer. So the most important and sometimes one of the most complex symptoms is pain. Not everybody who experiences cancer will get pain, even though it's a widely held belief that cancer equals pain. However, in pancreatic cancer, it's uncommon for people not to have some kind of pain, which often needs specialist attention. Other symptoms which can be difficult are things related to the motility of the gut itself, and people often have a great deal of trouble with difficult constipation. This is called a motility disorder, and this has directly resulted to infiltration of the nerves around the area where the pancreas is that affect the way the whole gut moves. So people can have problems with nausea, nausea and vomiting, with feeling full quite early after meals, and they can also have very difficult constipation problems. And again, an understanding that this is likely to happen, warning people at the time they're first diagnosed that there's a range of symptoms, having them understand what's likely to happen so that they can let somebody know.
Because she was trying to live her life the way she had before, she wanted to walk every day and everything, and the diarrhoea was probably her most debilitating thing, and with that went this constant feeling of fatigue and weakness and all the other things. And we did have a lot of trouble trying to find ways to help her with the diarrhoea, and you know, there were a few chat boards on the internet that I was looking at, and that was a common thing. People would write in and say, how do I deal with the nausea? How do I deal with the diarrhoea? Because those are two very debilitating things to live with all the time.
Another really important symptom relating to pancreatic cancer is actually a very high incidence of depression, and it's a well understood association with pancreatic cancer in particular, and again it needs to be looked for, it needs to be addressed up front. It's as important, as I said earlier, to control emotional and psychological symptoms that patients are experiencing as it is to control their pain.
By the time we made that phone call, there wasn't time then to wait 2 weeks for an assessment and do all of that, and we ended up going to the doctor that day, and Mum was admitted to the hospice that day and she never came home. Now I reckon that in the last 6 months of her life she could have had much better quality of life had palliative care been involved in helping manage her symptoms, because they know that's what they know how to do. And Mum used to just wait until her next oncology visit rather than, so she'd put up with discomfort and pain for weeks and weeks waiting for these appointments.
There's often some debate about where it's appropriate to involve palliative care in the trajectory of any person's illness, and the answer from us in palliative care is that we should be involved in any life-threatening illness whenever the patient has symptoms, whether they be physical or psychological, that require expert advice.
I will usually refer patients to palliative care physicians very early in their course of their treatment.
There's nothing worse for patients who have a diagnosis of something like this than to be told, as they unfortunately still often are, there's nothing more that we, meaning us in the hospital system, can do. And palliative care is completely coming in to say that's never the case, that will never be the case. There's always plenty that can be done, and if other treatments are finishing or not appropriate, that's where palliative care really comes into its own and makes the running with an illness like pancreatic cancer